Now, speaking of jerking motion, myoclonic jerks are a little worse than tremors. These are involuntary spasms or twitching that you usually do not see in the newborn period. It's not quite as bad as a seizure, but as they become more pronounced, they can resemble a myoclonic seizure, or they might disappear like a single or multiple jerks of arms or legs. So if that repetitively happens, we score them for myoclonic jerks. So if the infant expresses twitching movements of the muscles of the face or extremities, or if the jerking movements of arms or legs are observed, we score them as jerks, not tremors. And probably one of the most severe cases that we've seen, and it happens in 2 to 11% of infants exposed to opioids, especially when they're untreated, is seizure activity. Now, there are a lot of studies that examine the incidence of drug-related seizures, but in all the infants who have experienced seizures, they did have other withdrawal symptoms before the seizures started. So many of these were babies that maybe weren't scored. They were born in a hospital that doesn't recognize neonatal abstinence syndrome. Many are born at home, and the mothers deny seeking care. So in general, these seizures occurred after the baby has had symptoms of neonatal abstinence syndrome, and usually they're about 10 days old. And we refer to these as tonic seizures, and that's just generalized activity like you've seen on TV or, you know, people having a seizure. It looks just like that in a baby. Now, sweating. We would score the baby on the Finnegan scoring system as a 1 if the baby has forehead, upper lip, or back of the neck sweating. Now, if we have the baby wrapped up in multiple blankets and it's very hot in the environment, we give that baby a chance to recoup that, and we would unwrap that baby. So if mom was holding the baby skin to skin, or if grandma was holding the baby and had, you know, a couple of Afghans on the baby, then of course sweating is a natural thing. But this is sweating when they're not in an environment that has heat. Next is fever. We do score and take vital signs on these babies every 3 hours. So we score 1 if the temperature is less than 101, so that would be 99 to 101. And the baby would score 2 points if the temperature is over 101. And we actually take an axillary temperature, which is a temperature under the arm. We don't want to do repeated rectal temperatures on these babies because that's just not safe. Now note, it might be important to keep the infant dressed consistently because you can see fluctuations in temperature if the infant's dressed in extra clothing. So if that's the case, unwrap the baby, dress him in normal clothing for the environment, and recheck the temperature. Yawning. Yes, all babies and all people yawn, but these babies yawn a lot. These babies will yawn more than 3 times within that 3-hour period. So during your observation of these infants, and as you can see, they require very close observation, if the baby yawns more than 3 times in the testing period, then you're going to score for yawn. Modeling. Remember I said modeling was that lacy look? You can see the skin of that baby looks like a purpley reddish lace. Modeling is a discoloration of the skin, and it resembles a marbled appearance of pink or pale white areas. In these babies, you will see modeling on their chest, their trunk, their arms, or their legs. So if modeling is present on those areas, the baby does score for that. Nasal stuffiness. Nasal stuffiness occurs when the nares are partially blocked due to the presence of exudates that makes noisy respirations. And they might also have a runny nose. So if the baby has noisy respirations because of a runny or snotty nose, generally newborns do not have this. So if a baby has nasal stuffiness, they do score. Now you can see how all of these things that we're scoring them for in and of themselves may not indicate neonatal abstinence syndrome. You know, a baby can yawn or a baby can sneeze, but the combination of all of these things adds up the score. So a normal baby may have a score of 1 because he has a stuffy nose, or he may have a score of 2 for a fever because he's sick, but he wouldn't have all of these symptoms that we're scoring for. These babies sneeze, and these babies will score if they sneeze more than 3 times in a scoring interval. And sometimes these babies are scoring more than 30 times in a scoring interval. So you may see a baby who sneezes consistently from between those 3-hour scoring periods. Nasal flaring. The picture on the right is flared nostrils. So we observe these babies breathing when they're sleeping, and if we see an outward spreading of their nostrils, that is a sign of nasal flaring. So if they have any nasal flaring during that testing period, that adds 2 points to the score. Now, an infant's respiratory rate is usually 30 to 60 and normally involves abdominal movement, so you can watch their little bellies move. But when breathing is labored, you'll see retractions in that picture of that baby with the pulled-in skin between the ribs. That's called a retraction. And that can be due to lung disease or an obstruction of airflow through their nose or their mouth or their throat. So if the infant's respiratory rate is greater than 60 breaths per minute, and we do count it for a full minute because babies are known to have periodic breathing, they score a 1. If they have retractions with that score of respiratory rate greater than 60, they would score 2 points. Now, when you're determining the infant's respiratory rate, the infant has to be quiet if crying is present. So, for example, last night when I was scoring a baby, he was starved. It had been a little over 3 hours. He heard his mama. He really wanted to eat, and he was crying. So, of course, he was sweaty, and he was stiff, and he had increased suck. So we really need to let these babies be quieted and count their respirations once they're quiet. I told you earlier that these babies have a difficult time eating. The infants will have increased rooting. Rooting is when they turn their head from one side to the other to look for food. But these babies have rapid swiping movements of their hands across their mouth. They're trying to suck on their fists, their hands, a binky, or anything that they can get in their mouth. And we also score a 1 if the infant attempts to suck on a pacifier while moving their head from side to side, and they cannot get the suck coordinated even enough to grab hold of that pacifier. Now, normally infants will suck at a steady rate without taking frequent rest periods to breathe, but in these babies, they do not have that well-coordinated sequence of suck and swallow and breathe. So they will suck and they will sputter, or they will chew and gnaw at the nipple on the formula, or if they're breastfeeding, which we'll talk about that, they're unable to form a continuous latch. And also, sometimes they will just suck so hard they will continuously gulp, and they don't even stop to take a breath. And that can lead to regurgitation. So these babies will vomit up their food. It's not just a little spit up like is in that picture. It's vomit 2 or more times and not associated with a little spit up during burp. Many times it's projectile vomiting, and it will shoot even across the bassinet. So if they have 1 or more episodes of projectile vomiting that might occur during feeding or after, then they would add 3 points to their score. Now, nearing the end of the score, we look for loose stools. So if the infant has had a stool in the previous 3 hours that may or may not be explosive, maybe a little bit curdy like cottage cheese, mushy or seedy, it has to be liquid, and they may or may not have a red buttock. So we score for liquid stools, loose stools, and also watery stools. So a watery stool is when the infant has a type of stool that leaves a big water ring on the diaper. So if an infant has red buttocks and does not have loose or watery stools, you need to look at another cause. So it may be that the red buttocks is not a sign of withdrawal. Maybe he just has some thrush or some other yeast or some other type of diaper rash like babies get. So that's for scoring, and that's how we score. And that's what we do every 3 hours for 5 days. And then we're going to talk a little bit about some statistics and how we treat these babies. What can we do for these families? So some of our statistics that we see here at Wheeling Hospital, of the babies exposed to opioids and other illegal substances, about 31% of those will have respiratory complications, 19% will have low birth weight. We definitely know that nicotine causes low birth weight, but so does illicit drugs. 18% have feeding difficulties, and 2% may have seizures. And today, neonatal abstinence syndrome is more common, unfortunately, and also more complex. Years ago, neonatal abstinence syndrome was a very rarely diagnosed disease. And it was only secondary to heroin or maybe morphine. But today, look at the list of drugs that neonatal abstinence syndrome may be secondary to. And remember, these can be legal and illegal drugs. We may have a mom that is on a prescription opioid. For example, we have had moms who've had spinal surgeries or kidney stones or other problems during their pregnancy, or they've suffered fractures or accidents where they've needed the opioid. And you have to look at how the benefits outweigh the risk. So even mothers who have prescribed drugs and their baby is suffering neonatal abstinence syndrome, they would still be treated just as if the drugs were unprescribed, because the baby is going to have the same symptoms. Other drugs that are related to neonatal withdrawal are nicotine and a lot of the SSRIs. So Paxil, Prozac, you've heard a lot of people be on a Prozac, Celexa, Zoloft, Effexor. Now, these don't have the degree of withdrawal that babies with exposed to opioids would have, but they also, being on an opioid with one of these definitely compounds that effect. Other drugs related to neonatal withdrawal might be opiates and opiate-like substances like the old Darvon or codeine or Talwin, but also non-opiates like barbiturates, drugs like chlordiazepoxide, which is Librium or diazepam that mothers may be taking for medical conditions. And yes, even diphenhydramine, which is Benadryl, and imipramine, or other drugs that might be used for diagnoses such as attention deficit. So what do we do for these babies? What do we do for them while we're scoring them? And if they don't yet meet the treatment scoring for the Medicaid-assisted treatment, which I'll tell you about, we start doing non-pharmacologic treatments from birth. So for these families, we teach them, and we have a special room in our nursery where the environment is quiet, the lights are dim, and there's no TVs or mobiles, so very little stimulation. We swaddle or wrap these babies snugly, and they love being held in a C-curve position. And a C-curve position is when we take their knees and we bend them up to their chest and hold them in that C. Also, we handle them gently, and we avoid any jerky or sudden movements, and we hold them firmly and close to our bodies. Now, we do have a cuddler program here at Wheeling Hospital, and this is a group of ladies who, many of them are grandmothers, retired daycare workers, retired teachers, even some retired nurses that will come in and volunteer their time to sit with these babies. Many times moms are busy with other siblings, or maybe they're in a treatment unit. Sometimes they go to jail. So if the moms are not present, we do have cuddlers that can come in and hold these babies in that C position. And we do have training programs for these cuddlers, because often these babies are on different machines, such as heart monitors and respiratory monitors and things like that that aren't just like holding a normal baby. What else can we do? Well, we can encourage skin-to-skin holding with the mother to promote bonding. So in this dark, quiet room, we'll also have the mom do skin-to-skin to comfort her baby. We'll teach them gentle rocking, holding their baby in a C-curve, soft singing, humming, or sometimes just a repetitive shushing sound. And we limit stimulation at the first signs of distress. So some of these babies don't like being sung to. Some don't like the humming or the shushing noise. These babies, we do offer a pacifier for non-nutritive sucking. These babies are comforted by the binky. They do feel better when they actually have something in their mouth sucking, and it will save the sucking blisters and the red and infected fingers that can happen. And then also a sling or an infant carrier, and even our nurses have infant slings and carriers that we would use for these babies. Another thing that we've fell in love with is a Mamaroo. And if you've never seen a Mamaroo, it's like an infant seat that you can set automatically to sway and make shushing noises. Some other nursing measures, we use gentle touch and voice to awaken and prepare these babies for care. We maintain the swaddle position. And when we do these babies' cares, we keep them wrapped up as much as we can. And when we do unwrap these babies, we use hand containment and a binky. So we will actually hold these babies with the palm of our hand in a tight position, even when we're listening to them breathe or to their heart sounds. And then certainly when we're done, we re-swaddle these babies and offer them back their binky so that they have some comfort. For feeding, these babies have a really difficult time feeding. It seems like they just can't get it together in order to suck and swallow, and so they're pretty miserable from hunger and from belly aches from all the air they take in. If a baby absolutely cannot eat, we will put a nasogastric or an NG tube down these babies and give them their feeds while they're sucking on a binky. We swaddle these babies as they eat and pull their hands into the midline. They seem to do better if we cross their hands over their bellies or their chest. We offer firm input to the baby's feet, so we sit in a rocking chair with the baby straight up and down with his legs bent and his feet straight up and down on your lap. We keep input and stimulation to a minimum, so it's a dark, quiet room that the rest of the normal newborn population is not in. We may place a hand over the infant's chest, so we hold the bottle with 2 fingers, and with our other 3 fingers, we're pressing firmly on his chest. And we can offer firm pressure to his palate to increase the quality of sucking. So sometimes you have to put the bottle in the baby's mouth and use 2 of your fingers to make his chin go up and down so that he gets the idea of sucking and swallowing. Now, obviously, our first choice is human milk, and the mom's own milk is preferred if she is in a methadone or Suboxone treatment program and is compliant. However, if there's other suspected substances of abuse, the mom should definitely not breastfeed. So babies or moms who come in that have been taking drugs off the street, it is simply not safe to let them breastfeed. But moms who are in a controlled Suboxone program, who are in a clinic, who are taking their prescribed Suboxone, we prefer them to breastfeed, and then we assist them with weaning when they're ready to wean from breast milk. And yes, these babies do often need treated with morphine as well. Now, if there is no human milk available, then we would just use a standard formula. There's no evidence for using a Sim-Sensitive or Gentle-Ease or any of those easy-on-the-belly formulas, although we will try that if general formula is not helping. But right now, we don't start off with any special formula. We just haven't seen the value in that. Now, loose stools, they can be the result of inadequate coverage of medication. So maybe we're not giving the baby enough drug. Maybe we're allowing the baby to withdraw too much. Not usually lactose intolerance. However, when a baby has consistent diarrhea for the first few weeks of life, he can develop lactose intolerance. So if patients are well maintained on pharmacologic treatment, hopefully there'll be no diarrhea. So pharmacologic treatment consists, our hospital uses morphine in tapering doses. So once a baby scores 2 8s in a row on the Finnegan scoring system, or 112, we would implement morphine, and it's a weight-based dose, and we wean it every other day as long as the scores stay less than 8. If persistent diarrhea occurs, we can try a lactose-free formula, and before the baby goes home, though, we try to get them back on regular formula. We work closely with WIC programs so that they get the correct formula that they need. And like I said, we don't routinely use a sensitive formula, but it is an option if we need to. Now, all of these babies need some kind of diaper barrier cream right from the start. We use Aquaphor or Desitin or whatever barrier you want to use, and we use this on every diaper change. If it becomes irritated, we might change to Desitin all the time. But we've also done some oatmeal baths on their bottoms. We've used oxygen blow-by to their bottom area. We've even made little baby spas and put their bottoms down in warm soapy water and created bubbles. We do all kinds of things to keep these babies' bottoms clean and healthy. And luckily, in the last year or so, we haven't had any problem because I think we pretty much have the barrier cream treatment down pretty well for these babies. Now, remember I said that other areas of these babies can become excoriated, the backs of their heels, the backs of their heads, their elbows, and we would use Aquaphor on those. And then we also have 2 products that are more or less like thick Band-Aids called Tegaderm or Duoderm that can be placed over their elbows or whatever part of their body is rubbing against the bed, just to protect it so that it doesn't have further irritation or breakdown. Now, opiates such as morphine or methadone are the 2 recommended drugs as initial treatment for withdrawal in newborns. We also can add phenobarbital and clonidine if they have severe problems. And our drugs that we use here at Wheeling Hospital are morphine first, and then depending on if the baby is doing well or not, we can add clonidine and phenobarb. And like I said a few minutes ago, the infants without signs and symptoms of withdrawal which means Finnegan scores less than 7 do not require medical therapy. But babies who have 2 consecutive scores greater than 8 or 1 greater than 12 will get the medication started within 2 to 4 hours after that score. So the more severe the abstinence, the greater the need to start the medications as soon as possible. Now, there is a risk in delaying treatment. It can cause increased infant morbidity. Vomiting and diarrhea associated with dehydration due to narcotic withdrawal is a real problem. So really these babies need to be treated and watched carefully, and treatment needs to be done really quickly for these babies. So this whole system is big on family education. There are so many things we have to educate these families on, and if you think about it, these families are in crisis. So we are educating these families on the traditional unit schedule, the equipment that we use, the healthcare providers that they see. We do have a nurse practitioner Monday through Friday that sees these moms. We do have a transition nurse coordinator that has been with this mother since her prenatal visits at her OB, clear through her nursery stay, and also does home visits. We talk about the disease process of withdrawal. We help these mothers get into clinics. We get them into inpatient treatment and outpatient treatment. We can arrange transportation. We can arrange whatever they need to get them to their appointments. We have to tell these parents about the plan of care. Here's what we're going to do for your baby's development. Here's why your baby is receiving morphine. Here's the Finnegan scoring tool, and I actually give the parents a copy of that tool, and these parents will often ask, what was my baby's score? So they understand the scoring tool. Kangaroo care is very important. This is a comfort mechanism for the baby and will often help the baby through those rough times. We talk about breastfeeding, when you should or should not breastfeed your baby, and we tell them the reason why they shouldn't breastfeed their baby. And then we actually have a contract that we can use for visitation and involvement. For those mothers that do not want to come in and be involved with their baby, but they still want to take their baby home, we do have a contract that says they must visit and they must be involved in that baby's care. What we prefer is family-centered care. So we don't want to be influenced by personal biases and beliefs that, you know, like in the first few slides about junkies or, you know, the mom, why didn't she just stop using when she were pregnant? I stayed away from Tylenol and Motrin, and why can't she stay away from opiates? We don't want those kind of feelings. So we use our third party or team approach, and that is our transition nurse. And our transition nurse, like I said, sees them from their OB visit, from the first time they're identified as needing assistance, clear through a home visit. And really we need to provide them with unconditional positive regard when we communicate with them, because like I said, these moms didn't just wake up and say, I want a baby that is born addicted to opiates. 99% of these moms want these babies. They want what's best for these babies, and they want to keep their babies. So just like when we educate normal newborn moms, we need to educate these moms when they're taking their babies home, but they actually have a lot more areas that they need educated on. We need to talk to them about nutrition, about overeating and undereating, excessive weight gain, reflux, diarrhea. Remember, these babies gulp and they always act hungry. They may be chewing on their fists, they're always sucking and rooting around. So a mom may think the baby is just hungry. We talk to them about medications they're going to be on at home. We talk about comforting techniques for the irritable baby. And finally, we talk about SIDS prevention, because these babies do have an increased risk of SIDS. Other items that we review are shaken baby syndrome education. We talk to these moms and dads about grief, about coping, about getting the help that they need. And before they leave, we actually look at their family structure. All of these moms receive a social service consult. Our social service worker will make sure that a WIC consult is made, that a home study is done by our transition nurse, that our transition nurse is scheduled for a home visit. And we actually have very few parents who refuse to have that service. We work very closely with CPS, and with our CPS partners, we will tell them, you know, we want to do this home visit with our transition nurse, and CPS or Child Protective Services will actually make that a condition of going home. That yes, you know, you will attend your counseling and you will permit a home visit. We talk about immunizations, because many times these babies are in the hospital for their 1-month immunizations. And we teach them about their hearing and state screen results, which all normal newborns have. We talk to them about follow-up plans in the developmental clinic and all of the different things that they're going to need to keep up with. And we actually make sure they come to their appointments. So if they have a pediatrician appointment scheduled, which are always scheduled for 2 days after discharge for these babies, we then call and make sure these babies have shown up. And if they don't show up for the appointment, we call the home and see why not. And if it's a reason such as transportation or something we can, help with, we can do that. Or maybe we need to contact Child Protective Services and let them know that the mom is not being compliant with her home plan. Short-term follow-up for these babies, like I said, is within 2 to 3 days after discharge. Hepatitis screens, many of these moms are positive for hepatitis, especially Hep C. Growth and nutrition monitoring, these babies have a tendency to overeat. And pediatricians can make the decision to perform developmental screens. And there's different screens out there that we have, and these babies are screened from their first pediatric visit. We also encourage referral to community services. So our transition nurse and our social service will make referrals for birth to 3, home visits, Easter Seals, Head Start, etc. So these families are referred to these community services as well. And then long-term, because we don't know about their neurodevelopmental sequelae, many of these babies may have ADHD, and that's not detectable until they're like 4 to 5. They really need long-term follow-up, and that can't be overemphasized to these families. They really need to make an effort to prevent losing these patients to follow up and to keep them in the system. And one of the ways you can do that is by that unconditional positive regard, still while keeping the baby safe, but also supporting the mother. Now, a little bit ago, we talked about smoking and how it impacts neonatal abstinence syndrome, and this is just a little chart that tells you on the left is the amount of morphine that we have to give the baby. So you can see that a non-smoking mother, the baby receives or requires a lot less morphine than a mother who has a lot of smoking. So if a mother smokes cigarettes and is also addicted to opioids, her baby's length of treatment will definitely be longer. Here's the length of stay. The length of stay for a non-smoking neonatal abstinence syndrome baby is about 8 days, where it goes up to over 15 days for a mom who smokes. Now, we definitely need to do high-risk pregnancy referrals when these babies or when these moms are first diagnosed, even before the baby is born. Child Protective Services is not involved before the baby is born, but we do the SBIRT training in all of our OB offices, and we also have the on-site social worker and transition nurse. So they work really closely with our OB offices. All illicit drug-exposed infants are referred to social service, and social service, because we are mandated reporters, report that to the appropriate county CPS. I have seen, and we suffer from very inconsistent handling of these cases. We have some counties that are very proactive and actually will take custody or give custody to a family member until the mother is in some kind of treatment. We have other counties that will say we will see the mother at home and do a home plan. We also want to provide them with in-home services, and sometimes CPS will do that. And finally, foster care. Now, that rarely happens. In our 3 years, maybe only 2 or 3 babies have been removed from the family. So what kind of systems can we do for our community? Prevention seems to be the most reasonable approach. Really, we don't want to have a baby born addicted to drugs, but unfortunately we do. So we try to prevent them. We start them early, and we do education in our schools. We work with DARE and resource officers. We work with drug-free clubs. We work with local clinics and methadone treatment facilities. And if you've seen lately, there have been videotapes of neonatal abstinence syndrome babies featured in the news, and they are showing these to different news agencies and also different commercials. You've probably seen that recently on TV. Awareness is definitely increasing. Awareness of these problems really needs to be raised in the community. We partner with our pediatricians, our emergency departments, our OB/GYN providers, our treatment centers, and we have our poster campaign and pamphlets that we have developed. And we have a pamphlet that is specifically for pregnant women, We have a pamphlet, what to expect after your baby is born. And finally, we have a pamphlet all about feeding, and it addresses breastfeeding and formula feeding. So we talk about resources and programs for drugs and other substance addiction treatment through our transition nurse, and we also spread that information in the community as well, because we want these mothers to seek OB care. The last thing we want is for these moms to avoid her prenatal care because she's worried that her baby will be taken from her. So there's very few studies that show the effects and the long-term effects of neonatal abstinence syndrome on babies. But here is one. By 7th grade, 4 out of 10 neonatal abstinence syndrome children fail to meet state-mandated test scores. There's also another test out there that I read recently that children whose mothers smoked marijuana during pregnancy have an IQ score of at least 10% less than their peers. So because this problem is so new and it's only a few years old and it's only been identified and treated for a few years, we're just now seeing these students start to become in school. So you're just now starting to see some of these studies. So we are under renovation. This is actually our old therapeutic room. And some of the special things we did for this room were decrease the lighting. We have white noise. We have soft colors, and we actually have privacy screens. We're actually going to all private rooms and rooming in, and we're real excited about that. We have these babies treated on a brand new floor, and we have a playroom for siblings. We have a room on the top right that kind of looks like a hotel room. It has a mom bed, a bassinet, a rocker, recliner, a desk, a TV, and its own private bathroom. So we find that taking care of these patients as a family, rather than just having the infant in the nursery, really decreases their length of stay. It decreases the amount of treatment that they need, and it really produces a much healthier outcome, because as that mom is there taking care of her baby, we can see her family, we can see what kind of support she has, we can see that she's going to her doctor's appointments. So really, if taking care of the family is really the goal, and is really will give you the best outcome if you treat it as a family-centered problem. So that is my lecture on neonatal abstinence syndrome. I'm happy to entertain any questions. I can give you all my email if you want to email anything specific. I'm happy to share pamphlets or any other information that you need. Just ask.